Thank you.
Yeah, thank you. The next speaker is Dr. Lathika VK, and she'll be talking on impact of glycemic status on CCT and IOP in diabetic patients, a prospective study.
Good morning, respected judges and dear friends. I thank KSOS for the opportunity. Today, I'll be presenting a paper on the impact of glycemic status on central corneal thickness and intraocular pressure in diabetic patients. So, the unholy nexus between diabetes and glaucoma is well known. Prevalence of glaucoma itself is quite high in diabetics. So, glycemic status can influence CCT and CCT influences IOP. So, it is only a logical conclusion that glycemic status influences IOP. But the question what nagged us was, having known all this, are we actually factoring in this knowledge for the benefit of patients? Are we considering blood sugar levels while making glaucoma related decisions in diabetic patients? This is what prompted us to do this study, because the reports suggest variable links between these three parameters, and there are no lucid recommendations that we can make out from these reports on how actually to translate it into practice, whether it is the FBS or the PPBS or the HbA1c, what we should be looking at. So that is why we designed the study to study the impact of glycemic status on CCT and intraocular pressure in patients with diabetes. It was a prospective observational study done in a tertiary care teaching hospital over 18 months on a sample of 60 patients who were recruited by consecutive sampling. And the patients we recruited were all uncontrolled diabetics with a PPBS of more than 200 and HbA1c of more than 7. Any pathologies that could alter the corneoscleral architecture, high refractive errors, long-term ocular medications or steroids, systemic diseases that could influence IOP, and patients who were unable to be positioned for ideal ocular examinations were excluded from the study. So the study group underwent a complete ocular examination, and we measured the CCT using the Carl Zeiss SDA's OCT 5L raster mode, and the IOP was measured using the Goldman applanation tonometry. Glycemic status was recorded and control advised, and follow-up was done at 1 week and then after 12 weeks, that is 3 months. So at each follow-up visit, all these things were repeated by the same examiner and data analyzed using the SPSS23 software. So changes in CCT and IOP were basically analyzed using the pair t-test between each visit and ANOVA test across the 3 visits, and a p-value of less than 0.05 considered significant. The mean age of the study was 58.5. Most of them were over 50 years of age, and males constituted 63.3%. Most of the diabetic age was around 5 years or less. So coming to the actual results, we first looked at how the glycemic level changed over 3 months, and both FBS and PPBS showed a statistically significant drop from baseline at a follow-up visit of 1 week and also at 3 months. But what I want you to focus on is that this drop was mostly in the immediate phase. That is, both FBS and PPBS went down drastically in the first week itself after proper treatment was initiated, whereas the HbA1c decreased by about 4, it took around 3 months for the HbA1c to come down. So we looked at whether CCT changes paralleled the glycemic status changes. So what we found was that there was a statistically significant variation in CCT across the 3 visits. However, the mean difference in CCT between baseline and 1 week did not parallel the glycemic control that was obtained during that period. In fact, the CCT came down only after 3 months. The same happened with IOP also. So the IOP trend was parallel to the CCT trend. The IOP did show a decrease after 3 months, but not after 1 week. It did not parallel the sharp drop in glycemic status. So we have other studies which have come up with similar findings as ours, in the sense that the CCT has been found to be higher in hyperglycemic states and in diabetic populations. And there are some studies which are a discordance with us also, but the actual influence of FBS and PPBS and HbA1c has not been compared to each other. Our study has had certain limitations and strengths. The design of the study wherein we follow up the same cohort of patients over time, minimizes other confounders affecting these results. That is one thing. And secondly, it is a reflection of the real life situation that we are facing, where we are following up the same glaucoma patient over time. So it makes sense to replicate that particular situation in a study design. So these two are the strengths of our study, whereas we did not do a specular microscopy and we do not know the corneal endothelial status of these patients or the mechanism. Doing that would have contributed potential insights on the underlying corneal changes as well. So to conclude, optimal glycemic control did lead to a notable reduction in CCT values and IOP values. Short-term glycemic fluctuations as measured by FBS, PPBS did not influence either of these parameters significantly. Stable euglycemia, as evidenced by hemoglobin A1C levels at 3 months, produced significant drops in CCT and IOP measurements. And so, stable glycemic status is essential for a reliable IOP measurement in diabetic patients. So, what is new about this? The new thing is that, as I said, the relative significance of FBS, PPBS and HbA1c on CCT or IOP was explored in detail, and the design involving a single cohort reflects real-life scenario. This study gives clear-cut evidence on how and how frequently a clinician should assess glycemic control in the context of glaucoma diagnosis and management. We know that Kerala is the diabetic capital of the world, so we have to translate this into evidence-based medicine, and we recommend that healthcare providers should look into glycemic status, specifically HbA1c, at least once in 3 months when you follow up the glaucoma patients and make glaucoma-related decisions in diabetic patients. FBS, PPBS monitoring at each visit, however, is neither necessary nor practical. These are my references, and I thank you for your kind attention.
Good thinking, Ma, and good. You projected well and presented well.
Thank you.
So, as you say, the CCT level varies with your glycemic status. So, you will make your correction also, no IOP calculation.
I have not found out the factor by which the glycemic status produces a corresponding correction. Actually, if we can find out how much is the actual relation, we can probably think of correction tables.
What you're showing the thickness.
Yes.
When it goes to correction, what is the proportionate change?
Per unit change, if we can calculate, it will be very useful to make correction table.
And correlate with your HbA1c, it will be a triple. As you said correctly, FBS and PPBS is
doesn't make sense.
It doesn't make sense. It will be good. But only thing every 3 months.
Everything. And
HbA1c is not only good for the eye, it is good for the patient also.
Exactly. So it is practical.
Correct. Good study, Ma.
Thank you, sir.
Is there any, did you look into the HbA1c levels and central corneal thickness? Levels of, you selected all patients with more than 7 or?
Yes, that's what I did.
You calculated the status of the HbA1c and the central corneal thickness? Is there any relationship between the?
Yes, there is. Actually, HbA1c levels, when the HbA1c levels come down, only the corneal, and when it is going more than 9%, it is becoming more significant.
That also you calculated?
Yes, that cutoff, yes, it was there. We did look at that.
You included diabetic patients with glaucoma or?
No, we included just diabetic patients.
Diabetic patients.
Yes, because even in the screening this becomes important, not only in the diagnosis. So we included diabetic population as such.
So thickness increases. What is your theory? Is the edema?
Actually, the literature shows up some mechanisms by which the corneal CCT increases.
That time we had to think about corneal hysteresis.
Yes,
also.
but we could not assess the corneal thickness in this population because we didn't have a specular microscope.
Okay, thank you.
Thank you so much.